And we go to the radiotherapy. Thomas Wiegel from Germany is talking about this perspective.
Thanks a lot for giving me the opportunity to present the radiation oncologist's view on this point. Progress in radiation oncology is growing step by step, and I will show you some of the next steps we are still awaiting. The old question of adjuvant radiotherapy or early salvage radiotherapy, the solution is coming nearer, and you know from today that there are clear data that indicate that adjuvant radiotherapy in high-risk patient works, but it is not used as it is expected. It is argued as today that about an overtreatment for 40% is there, but when you have a look on these things, you see this is a ARO trial, a randomized trial. You see that patients with high-risk features, that means PT3 tumors with Gleason score of 7 to 10 and positive margins, nearby all of these patients will recur within 10 years, and it goes down more. The next point is that there are a huge rate of severe side effects. That is clearly wrong. If you look for the old data, then you see very hard side effects, but these are old data. In the newer area, this is only 3D planning without any IMRT. 1% of severe side effects, not more. So we have clear indications for patients with adjuvant radiotherapy, these high-risk features, until we, in latest 3 years, we will have the results of radicals. And radicals will not give only the results of immediate adjuvant radiotherapy compared with salvage radiotherapy. It will also give results of the duration of additional ADT compared with radiotherapy alone. More than 3,000 men have been enrolled, and it's closed now, and we still await the results about in 2019 or 20. The point is then adjuvant radiotherapy or early salvage for persisting PSA or for increase of PSA after radical prostatectomy. And perhaps this group is underestimated until now. This is also the results of the randomized ARO trial, and we took the patients out, planned, who had persisting PSA that were 20% as we have today, and the 10-year data published in the Red Journal clearly show that the carcinome-specific survival is less in these patients with persisting PNA, and all had salvage radiotherapy directly. So perhaps persisting PSA has different biology compared with a PSA increase, and within the next 2 years we will focus in much studies on these subgroup of patients. What is with salvage radiotherapy? There is a problem with the dose. We have a clear problem with the dose. The guidelines say at least 66 gray, and this is a major meta-analysis of all studies we have until last year, published by King. And you see 1 gray more is 10% better recurrence-free survival. So it's very easy to higher the dose, but we don't have the data. What is the problem with the dose we have? This is about a retrospective study about 300 patients, half of these IMRT, half of these 3D. And you see that with IMRT we have nearby no problems, but for genitourinary toxicity, even with IMRT, we have up to 15% of grade 2 or 3 side effects. So there is a problem with the dose, and we still await one study, one randomized trial coming from Swiss. That's the ZAC 0910 trial, comparing a dose escalation dose from 64 to 70 gray, and within the next 2 years we will have these results. The next problem now we have is a combination with ADT for salvage radiotherapy, and we have 2 randomized trials showing different possibilities what we have to do, 6 months versus 2 years. But the question now is who really do not need additional ADT, and we have to look for these guys. Perhaps it is possible to select these guys when you irradiate very early with a PSA before it is 0.2, very early, a clear advantage in this situation, and it translates when these patients achieve an undetectable PSA again into a better overall survival. That's only retrospective, but it's in line with the Stevenson data and other data published in the JCO, and there it is very important to look for these patients. Who do not need additional ADT? It depends. On what? We don't know. Perhaps very early PSA below 0.5. Perhaps we can wait when the PSA post-SRT is undetectable. because ADT is not without side effects, and it's clearly not recommended for all men. And within the next 2 years, and then with radicals, we will have a lot of new data, and then we can find the guys who can we spare this therapy. What's with definitive radiotherapy for locally advanced PCA? Hyperfractionation. Sometimes it's important to say what will not appear within the next 2 years. You know, hyperfractionation for localized disease, that means higher single fractions, lower total dose. This is, in the situation for localized disease, even for high-risk patients, a clear now standard since the last year. But we don't have one prospective trial for locally advanced tumors. And so hyperfractionation, with all its risks, is not standard for locally advanced PCA within the next 2 years. What is with locally advanced PCA and positive lymph nodes? You have seen these data, and it's clearly shown that in the majority, these patients for the moment are not treated. And still we are waiting phase 3 trials. I think this will increase in the near future because even the majority is not treated, and the results, even retrospective, are very impressive. But what is clear, over the time, urologists and radiation oncologists still became more friends. And it's like friendship will ever be. No one clearly knows what will be within the next 60 seconds. Thanks a lot.
Any question from the audience? I have a question, Thomas. I mean, we all know that in post-op we have a problem of dose with respect of toxicity. But this could mean that we should favor adjuvant and not salvage, because we all know that when we deal with salvage, we also deal with microscopic disease. And this means more dose or dose similar to radical radiotherapy.
Yes, and the question?
The question is, are you favoring adjuvant and not salvage?
No, I favor both for the correct, optimal patient. And I think we have the possibility to find out these patients, and we have clear data. But perhaps in 2 years, when radicals will present, the data will be presented, we have to change a lot of these sure treatments we think.